Hello GSLS attendees. Thank you for your interest in this session on the Medmont Meridia in Myopia Management, working together to improve care. My name is Randy Kojima. This session is sponsored by Medmont International. It's also sponsored by Precision Technology and Cardinal Contact Lenses, the North American distributor of the Medmont Meridia. Many of you here at the Global Specialty Lens Symposium will know the Medmont as being the gold standard in corneal topography, and its application specifically in specialty contact lenses. But with the new imaging options this instrument can now acquire, you have a tool that allows you to place a patient in front of the instrument and perform so many functions. We'll introduce some of these new imaging and dry eye features later in the session. The focus of this talk will be on using the Medmont Meridia in myopia management. How do we use this tool prior to orthokeratology treatment to understand candidacy? How do we use it post-treatment to assess the outcomes and determine if changes are necessary and what those changes should be? Now, in designing an ortho-K lens, we know that we have to get many things right. The base curve to cornea relationship, the sagittal depth, the alignment with the peripheral cornea, the edge lift, the toricity, the diameter. There's so much that needs to be designed appropriately for an ortho-K lens to fit optimally. And there are many ways that we can approach the fitting. But regardless of how we actually begin in ortho-K or any specialty contact lens, it's based on the data and the accuracy of that data. So understanding eye shape, understanding the depth, understanding the size of the cornea, using the software to model the fit of lenses prior to ordering the actual lens. So the topographer is really a very important part, and its accuracy obviously important to our first fit success. Now, how accurate is a Medmont? For those that have never used a Medmont topographer and are thinking about topography and maybe thinking about a Medmont, is it the right choice? And in this study at Hong Kong Polytechnic by Tan and colleagues, they found that when using the Medmont topographer and the bee-free orthokeratology design, their first fit success was 95%. Now, this is a specialty lens. This is an orthokeratology lens, a reverse geometry lens, a very complex construction, and a lens worn in the closed eye environment, and it needs to work in a place where we can't even evaluate it. So the baseline topography becomes very important, and clearly the Medmont is accurate for understanding eye shape to be able to achieve such a high first fit success. Now, how can the Medmont Meridia be used to create orthokeratology efficiency in your practice? Well, let's look at a case example. We know that a small cone topographer like the Medmont gives us an incredibly large surface area of coverage, generally over 10 millimeters of data, even on this steep cornea. Using the proprietary Medmont composite eye capture, we can fill in the peripheral cornea by changing fixation and merging all of those images that we take together to create a larger view of the eye. And this is important related to ortho-K lenses and any large diameter lens, because we are needing a lot of that peripheral corneal information. So one of the reasons to think about a Medmont is its corneal coverage in addition to its accuracy. Now, when we're evaluating a patient before fitting, what do we look at? And one of the first things that we want to select is the axial interpretation. And that helps us to understand the powers that are distributed within the pupil. Is this a very straightforward and simple case? And here we can see a very spherical cornea. Nothing very complicated about this fit. So in terms of candidacy, we're thinking this is a good candidate for ortho-K. Now, what about the shape of the eye? And that's where we pull up the Tangential Map. And you might notice something unusual about this topography that's picked up by the Tangential Map, but is not so obvious in the axial. And that's that ring of blue that's very concentric. This patient removed soft lenses just prior to having the topography performed. And what we may be seeing is one of the junctions, the optic zone most likely, of the lens that's creating a molding of the anterior surface shape. So prior to starting ortho-K treatment, we might want to consider washing the patient out of lenses until the corneal shape has returned to normal. And in soft lenses, that may only be a day if it's HEMA or 3 days if it's a silicone hydrogel. Another thing that we can look at pre-fitting is to use this Medmont contact lens displacement attribute. And what it does is it allows us to place a circle around the zones of the cornea, in this case, the cap of the cornea, this blue-green border. And what we see is the corneal cap is slightly displaced, 0.24 millimeters toward axis 270 based on the tangential map. We can perform the same function on the axial map, and we see slightly less decentration, 0.09 toward axis 240 degrees. But ultimately, what both these measurements are telling us is that the cap of the cornea is slightly inferiorly displaced, and that's going to affect the contact lens centration in the closed eye environment. As that lens finds equilibrium, it's going to center itself based on the natural rate of flattening of the eye. Using the Medmont and this contact lens displacement attribute, you can determine before you even start ortho-K if a lens should be expected to center well, or if you should expect some decentration of your outcome. And this can help to determine if modifications should be made, or if the fit is likely as good as it's going to be. Now, when we assess the metrics of the topography, what are some of the things we look at pre-ortho-K? And of course, the K readings. How steep or flat is the cornea is one of the considerations. The steeper the cornea, the better the candidacy for ortho-K. Flatter corneas tend to be tougher to squeeze out more effect. This patient has a slightly steeper than average cornea, so that would make it a good candidate, along with the low corneal astigmatism certainly would suggest we have a very straightforward case for ortho-K. We could look at the eccentricity. Normal E value with your Medmont is about 0.65, and this patient is coming up 0.34 on the flat and 0.48 on the steep. The lower the eccentricity, generally the lower the potential for effect in ortho-K. So having a slightly lower pre-ortho-K eccentricity might suggest that higher myopia may be tougher. For instance, trying to achieve a -6, 7 or 8 diopter may be out of range. Another thing that we can look at is the sagittal differential. The Medmont highlights this value so it's easy for you to understand before you start whether a symmetric ortho-K or toric is recommended. And the same is true of corneal GP fitting. The higher the sagittal differential, the higher the peripheral toricity. So what we're looking at is the depth of the flat meridian compared to the depth of the steep meridian. And the difference in height, in this case, is only 1 micron. Eyes that are 30 microns or greater typically benefit from toric landing rigid lenses, and in this case, toric landing ortho-K lenses. Another important consideration related to any specialty contact lens is visible iris diameter. Using the Medmont to define the VID will be helpful in customizing the lens for each individual eye. For instance, in corneal GPs, an old rule of thumb was visible iris diameter minus 2.3 millimeters. In orthokeratology, VID minus 0.8 is a typical starting point. And in scleral lenses, the visible iris diameter plus 3.5 millimeters is often a minimum starting point for lens diameter. So for this patient with 11.9 visible iris diameter measurement, a corneal GP of 9.6 might be chosen based on the formula. An ortho-K lens of 11.1 would be appropriate for this eye. A scleral lens no smaller than 15.4 would be recommended. Now, the Medmont contact lens software is something that I personally rely on very heavily for all of my rigid contact lens and specialty lens fitting. It allows us to model the landing, the lift, the vault of the lens before we even begin, and to ensure that we have the right lens to cornea relationship. This can be a valuable tool in achieving a high first fit success in ortho-K or any rigid contact lens. Let's just highlight the specification screen for a second, and you'll note we enter in the patient's spectacle RX. The visible iris diameter will provide the software with an understanding of a starting point, a recommended lens diameter. We can choose an optic zone that's appropriate, whether this is myopia control or adult ortho-K. The toricity of the peripheral cornea was only 1 micron, so certainly a toric lens would not be called for in this case. A symmetric landing would be appropriate. So with very little information, the software constructs the appropriate base curve to cornea relationship, the depth of the reverse curve to create the sagittal depth that we need. The software will determine the appropriate alignment zone shape and edge lift to create an optimal outcome. So even if you're a relative neophyte with ortho-K or topography, you can let the technology do the work for you. One of the exciting new features of the Medmont Meridia Pro is its ability to image and video the fluorescein patterns of our lenses. And this can be helpful when we're trying to document or we want to communicate the fit to the lab for assistance. So you'll find that this option added to your corneal topographer creates a powerful tool in our specialty contact lens practices. So now we're at the point where we have a good orthokeratology fit and we need to send the patient home to sleep in their lenses. And then we find out how they worked. And of course, the slit lamp exam is one of the most important observations that we're going to make after wear. We may choose to put the patient behind the phoropter, but for the most part, it's effective to do just a simple visual acuity check and then let the topography tell us about the vision. So after wear, most of the understanding comes from the topography and how we've altered the eye shape. When you look at this post-treatment topography, what would you presume was the outcome of this fit? Was it the optimal bullseye, a well-centered treatment that created the appropriate effect? Was it a central island creating apical steepening? Was it a flat-fitting lens where the treatment zone and effect was high? Was it a steep-fitting lens where the opposite is true and we have a low-riding lens and a low effect? Well, when you look at this post-treatment topography by itself, what would you diagnose this outcome as? Bullseye, central island, smiley face, or frowny face? Now, this is where we want to use a function that the Medmont provides called the Subtractive Map. And what that does is it compares pre-ortho-K from post-ortho-K and gives you the difference. So A minus B equals C, and you can understand how the eye has changed between those two visits. With this subtractive map, we might look at the effect in relationship to the pupil. And here we follow the border of the blue treatment zone. And it appears that that hydraulic effect is displaced high, giving us a blue treatment zone that's decentered superior in relationship to the pupil. So the axial map helps you to understand the treatment zone position. Now let's click our cursor right in the center of the topography on the visual axis. When we compare the power before ortho-K to after ortho-K, we can see that there's a difference of 2.34 diopters. In other words, we gave this patient a 2.34 diopter reduction in their myopia. So it's really unnecessary to do a full phoropter exam for the patient. The topography is going to give us excellent perspective on the shift in myopia. Now let's switch over to the tangential map. And this is useful to understand shape in any of your assessments using the corneal topographer. The tangential map is the most sensitive to points of curvature change. And here, what it's highlighting post-ortho-K is the area of the reservoir where you have the suction force pulling on the epithelium. And I've drawn in this dotted green circle to highlight the inner ring of this effect. And what you see is that that ring is decentered superior in relationship to the white pupil here. Again, both the axial map and the tangential map are saying the displacement is slightly superior. Now, when we look at the axial and the tangential map collectively, they're telling us that we have the smiley face outcome, the high riding lens in the closed eye environment, creating an effect on the eye surface that is displaced superior. Now, a smiley face is caused by inadequate sagittal depth and lens that may be hitting the central cornea and being pulled up by the lid. It could be caused by a loose alignment zone, a lens that's just too flat for the eye. It could also be caused by a lens that's too small on a large cornea. In this case, we didn't have central corneal staining. We tightened up the alignment zone, and that resulted in the appropriate bullseye. Now, the blue treatment zone does appear to be a little bit high in this case, but it's still pretty well centered to this pupil. When we switch over to the tangential map, we see a red ring that really follows the pupil border. It is slightly high, if anything, but it's very much within range of what we would argue as a bullseye topographical outcome. Now, you've seen the outcome for this particular patient where we had a smiley face and we corrected it by tightening up the alignment zone, and we have a good bullseye with quality vision. But I might ask you, is this a good myopia controlling bullseye? What would tell you that this ortho-K effect should actually create an optimal myopia controlling outcome over time? Well, let's look at the axial map in a little more detail, and we'll focus in on the area of this pupil. Notice at a 5 millimeter pupil, we see the range or power spread that's distributed within that central cornea from most minus to least minus at the pupil border. If we look at the center effect, it's approximately minus 4¼ diopters. We've created a 4¼ diopter myopic reduction. If we look at the border of the pupil, it's approximately plus 75. So there's an absolute shift in power of 5 diopters, or you're creating a myopia defocus dosage of 5 diopters, or thought of another way. If this were myopia control with a soft lens, we'd want to use a high add product to try to slow down the eye growth. And for this ortho-K case, we're creating a 5 diopter add for this patient. What we would expect would be a very good myopia controlling outcome. Now, if any of this seems complicated, what do I do prior to ortho-K when I'm assessing that baseline topography? How do I build the initial lens? After I fit the lens, how do I assess the post-treatment outcome? What if you're a neophyte to ortho-K? What if you're relatively new to corneal topography and the Medmont? Well, the story is it's quite simple for you to share your information with the lab. Your Medmont allows you to collect all of the images that you'd like to send to your consultant. The baseline topography to build the initial lens, the initial fluorescein pattern of that fit if it required modification, the subtractive map, the pre and post topography. All of these images can be exported in a digital file, which allows your consultant to open it up and interpret and manipulate the data as if they had taken the topography themselves. So the Medmont export file is a wonderful way that you can share information digitally with your lab. Now, earlier in this session, I said there was multiple imaging options available with the new Medmont Meridia Pro. And that allows us to take white light images, fluorescein, myopography images, and using their ultra high resolution camera, we have this incredible photography available from this corneal topographer. Now, while it's one of the best corneal topographers on the market, I might also argue it's one of the best imaging systems that I've ever seen. Each of the imaging options, the white light, the fluorescein, the infrared, myopography, they all share the same controls. So that's helpful for the user because you really only need to understand one set of functions to know what to do to optimize your capture or your videos. Each share a focusing window that helps us to really create the best possible imaging on each eye to get the sharpest focus possible. We have direct illumination control while we're on the fly with the patient behind the instrument and be able to observe how much higher do we need to up or reduce the illumination as we're taking the images or video. And the settings are accessible to us so we can customize to create the best possible outcomes with both our imaging and video. Now, one of the new features that I absolutely love and use frequently is the Fluorescein Capture. And this has been a wonderful way to document the fit of our specialty contact lenses, to be able to share this information with the lab. And the illumination and optics are so good that we can actually make out SPK on the eye, and it gives us a really good understanding of the surface health of the eye. It's virtually a slit lamp in many respects. And another thing you'll notice is the way it illuminates with light sources on either side, nasal and temporal. You notice this very even diffuse illumination. So it's not like our slit lamps where we have one point or one axis of illumination with shadowing on the opposing side. We really get these beautifully illuminated anterior segments. The white light capture is similarly enjoying the benefits of the high resolution camera and that illumination that's so even across the entire field. And clearly the resolution and the illumination is really impressive, but so is the depth of field, allowing us the ability with one image to appreciate the conjunctiva, the lid margin, the eyelashes. The camera and the way this system works for imaging the anterior segment is really quite impressive. And for all of you that are at the GSLS because you love the fitting of specialty contact lenses, the white light assessment and that large field of view becomes very beneficial when we're imaging some of our toughest contact lens fits, and being able to share this information with the lab to get some assistance to optimize the fit of this lens. And using the video function both in white light and with your fluorescein assessment allows us to document with the video the fitting, the movement, the centration of these lenses, and again being able to share it with the lab when we want some assistance with the construction of these lenses. A unique benefit of reflection-based topography is its ability to assess the tear film on the corneal surface and to give us an understanding of the tear film quality as well as the tear film breakup time. So in a non-invasive manner, our corneal topographer can give us an understanding of the point when we have tear film breakup. This tear film surface quality assessment, of course, is critical to dry eye practice, but it's also useful when mapping over top of contact lenses that patients may be complaining about wetting. You can then compare multiple different lenses to see which ones wet in very short order to determine what might be the best plastic for a particular patient. Using the Medmont Meridia Pro and its infrared light source now allows us to image the meibomian glands, again coupled with that high-resolution camera and software designed that allows us to best define the borders of each gland. We really have an exceptional tool coupled with our dry eye practice. Another application of the infrared light is to be able to measure the tear meniscus height without affecting the normal tear film homeostasis. You have grading scales for corneal staining, limbal redness, bulbar redness, meibography, meibomian glands upper and lower, palpebral redness, and palpebral roughness. And this can be used to create a dry eye report. Simply collect all of the images that you want to go into the report, then grade each one. You can add in risk factors to your report. You can add in data that comes from other instruments to populate in your dry eye report. And then that gives you something that you can provide to the patient that's both visual but instructive on where that patient sits in terms of their dry eye magnitude and the reasons for the treatment that you're recommending. The Medmont Meridia Pro is really an impressive instrument. For specialty contact lenses, Medmont has always been a powerful tool, regardless of the type of lens we were fitting, from corneal GP to soft to hybrid to ortho-K to sclerals. We've always had a tool that can help us to achieve a high first fit success. But now we have an imaging device that helps us to be more efficient. We can place the patient in front of one tool and do so much with that one tool. If you're interested in applying some of the new technologies that you've learned throughout this conference, if you're interested in being able to use the Medmont in the most advanced ways possible to improve the efficiency of your practice, the Precision and Cardinal team is here to help you throughout the entire process of learning how to use the instrument. The experts at Precision understand specialty lenses and topography together. They're going to be able to train you in multiple sessions how to take optimal topography captures, how to assess those maps, to understand thresholds of disease, to use it in your myopia control practice, to understand specialty contact lens construction in the contact lens software, rigid lenses, scleral lenses, hybrid, orthokeratology, and to use it for other things like imaging over your multifocal lenses. So this tool may arrive in your practice, but know that it's going to come with an exceptional level of technical support, because the person training you to use your topographer is not just a topography expert, they're also a specialty contact lens expert. So know more and know now with the Medmont Meridia Advanced Topographer. So visit the Medmont virtual booth during exhibit hours or schedule an appointment. During the GSLS, there's a promotion, so now's a good time to visit the team at the virtual booth to learn more. And for further information about Medmont products, go to the Medmont website. And if your practice is in North America, reach out to the Precision and Cardinal team at the information you can see on screen, the phone, email, or website. But if you practice outside of North America, go to Medmont's website and look for the international distributors and the one closest to you. Thank you for your interest in this session. I sincerely hope that it's been educational and there's been plenty to learn about both the Medmont and topography in general. For any questions, reach out to the Precision and Cardinal team or Medmont directly. Again, thank you so much and enjoy the rest of the Global Specialty Lens Symposium.